Morning for everybody. I would like to thank the organization for inviting me to be here today. And I try to talk about psychiatric comorbidities in children. Well, just to introduce the term, epilepsy in children, the incidence is about 80 cases for 100,000 inhabitants, the prevalence for 1% of population, and 1 in every 3 patients has an unstable course of epilepsy during lifetime. It means that these children may be chronically suffering from seizures and the comorbidities that affect them. Epilepsies may be divided into great subgroups, symptomatic, that have a great number of causes, and idiopathics. Both of these groups have comorbidities. In all of these patients, psychosocial aspects are involved. It means that even in children with idiopathic epilepsies, we can find some psychiatrist comorbidities. The most comorbidities of epilepsy in children are a great number. There are traumas, migraine, motor development disabilities. That's a major group in symptomatic epilepsies. Cognitive disturbance, attention deficit, hyperactivity disorder, autism, social isolation, depression, anxiety, suicide, psychosis, and others. In respect to comorbidities of children, we can find that psychiatric comorbidities are strongly associated with a negative impact in quality of life. It means that children that have chronic seizures may have difficulties to be introduced in the social environment and have difficulties to develop in the schools and have difficulties in apprentices. Chronic comorbidities, particularly psychiatric disorders, are not exclusively of patients that are having chronic seizures. Some patients that are seizure-free may have the same comorbidities. And this will be very prejudiced in patients in the adolescents. Children with epilepsy may have a reduction in academic performance, and the major factors involved in this are age of onset. The early age of onset will be worse for these children. Frequency of seizures, and patients that have many seizures will be worse than patients that have less seizures. Type of seizures, course of epilepsy, cause of epilepsy, and iatrogenic antiepileptic drugs that we sometimes have to use in large doses that will difficult the apprentices of the children. And the rate of epilepsy, of course. Almost half of the children with refractory epilepsy may involve some intellectual dysfunction. It means that they have just some difficulties in apprenticeship, or they have major mental retardation. And this decline may be progressive during lifetime of chronic epilepsy. And what about the benign epilepsies? We can think that patients that have idiopathic epilepsies with life duration being relatively small may have a better outcome. Not always it will happen. We can see that children with benign Rolandic epilepsy might develop cognitive, behavior, and other psychiatric disorders during the active phase of epilepsy, and these problems may outlast a long time for all their lives. So epilepsy is a part of the spectrum of this disorder. We don't know the answers. Maybe these children have some difficulties of development, some major anatomic and neurotransmitters communication that produces the difficulties evaluation. And what about attention deficit hyperactivity disorder? We know that this is a fashion disease. Now we that are in attendance clinics, we see that all children today have attention disorder, hyperactivity disorder. They commit approximately 3 to 5% of pediatric population at all, not just the children with epilepsy. And in the group of patients with epilepsy, this will be widely ranged for 8 and to 77% for some authors. Accompanying this disease, epileptic children will, with controlled seizures, will have, and with no intellectual disability, may differ from the general pediatric population, but these children may be at high risk of developing attention deficit hyperactivity disorder. If you analyze this study, we can see here that patients with idiopathic epilepsy, the number of patients that develop attention deficit hyperactivity disorder is about 7.5%. In the group of idiopathic epilepsy, generalized idiopathic epilepsy, this is almost the same percentage. It's about 8% of the patients. It's much higher than that observed in the general population of pediatric group. In this study, King et al. Evaluated 102 children. These patients have he divided the two groups, the population in two groups, these with attention deficit and these with not attention deficit, and the history of status epilepticus and the number of anti-epileptic drugs does not differ significantly between these two groups. So this is not a predictive factor to contribute to the occurrence of attention deficit hyperactivity disorder. And if you consider the other side of the coin, patients with attention deficit and that not necessarily have epilepsy. This is a great study with a large number of population that evaluated all children in the determinate period. And this have some with the diagnosis of attention deficit hyperactivity and some that have not the diagnosis, that is much higher. Here you have about 5,000 children with attention deficit, and we saw that the incidence of epilepsy in the group of patients with attention deficit is higher than that observed in group of patients that don't have attention deficit hyperactivity disorder. So you see that it's a correlation between these two situations. We don't know exactly who came first. Maybe attention deficit and epilepsy may coexist together, that they may divide the same pathogenic situation. Some studies demonstration that with quantitative MRI demonstrated that patients with attention deficit hyperactivity disorder had significantly increased in gray matter frontal lobe, and the smaller brainstem volume. So that's the structural alterations in patients with this situation, even if they don't have epilepsy together. And the decrease in the right anterior frontal region and loss of right to left asymmetries in striatal nuclei. So we can see that in patients with this situation, there are some anatomic aspects that may be involved, and this may contribute to certain form to the development of epilepsy. Functional MRI in children with attention deficit had a typical motor and sensory cortex activation. It means that it may be, to get, again, a situation that anatomic and the structural and the neurotransmitter may be associated with this dysfunction and may be a factor that facilitates the occurrence of seizures in these children. Also, molecular genetic studies involved that dopamine receptor and dopamine transporter genes are altered in this subgroup of children. Deficits in dopamine modulated frontal striatal circuits are correlated with subtypes of some attention deficit hyperactive disorder. In this way, all these studies demonstrate that this group of patients have structural, metabolic, neurotransmitter disorders, and this may be a situation that correlates both of these situations. Talking about depression, anxiety, psychosis, suicide, we may think that these situations don't occur necessarily in children. I work with children for almost 20 years, and what we see that is sometimes we are quite benign with the diagnosis of this situation. We can see that children are more hyperactivity, they have more aggressivity, they have more situations that with impulsivity, and we try to just consider this like a childhood behavior. But if we are more specific in the evaluation of these children, we can see that this situation is really different in children with chronic, particularly in the group of patients with refractory epilepsy. When we talk about psychiatric disorders or comorbidities, we can see a great variability of situations. And these situations may vary together with the intensity and with the severity of this process. We have some children that have just a depressed mood, and we have students that even try to suicide. Children with new onset seizures normally are more at more risk to develop this situation. In the first 6 months, are particular the time that these situations, particularly depression and anxiety, develop. And if we compare patients with epilepsy and his siblings, we can see that these children with new onset epilepsy have a much more incidence of depression, anxiety, and psychosis. Anxiety disorders are thought to be one of the most common psychiatric diagnoses in children and adolescents, and maybe it's not much different from that from adults. But here, again, we try not to consider the situation. Sometimes we have to stop our talk with the mother and the father and talk with the child to see if you can just consider or we can define this kind of symptoms in the children. Approximately 13 out of 100 children and adolescents experience at least one episode of anxiety disorder. This till the mean age of great prevalence is around 11 years of age. The most common anxiety disorder in children in adolescents are the separation anxiety from mother or father, depends the one that's most proximate to child. Specific phobias, and these phobias may be of darkness, of crowds, of school, of teachers, and social phobias. Social phobias, for me, I think it's the worst of the one that's this difficulty children to be socialized in school, difficulty children to be involved in situations with pleasure, with sports, and so on. Recurrent epileptic situations, stimulations of the amygdala may predispose these patients to interictal anxiety. So this anxiety is most all the time defined as chronic interictal. Among youth with epilepsy, it means the smaller children, increased rates of anxiety are correlated with polytherapy of anti-epileptic drug medications. And again, this means that patients with refractory epilepsy will be at most risk to develop this kind of anxiety and increase the seizure frequency. It means that this group, particularly that children, that even if it's for a short period of life, develop high-frequency seizures, and we need to use high doses and a large number of anti-epileptic drugs, will be at higher risk to develop this kind of symptoms, depression, anxiety. It's interesting to note that even that children with benign Holland epilepsy that sometimes have for a really not long-lasting period, but some children have 1-2 years of chronic frequent seizures, may develop this kind of symptoms, and these symptoms may prejudice the evolution of children for all these adolescents and the new adult life. Factors potentially involved there are fear of having a seizure, separation from one of the parents, that's frequent in children, even especially in small ones, but in this group of patients, these symptoms is much more frequent. And fear, the embarrassment of having a seizure in public. This is particularly real for the children that have, that is beginning of the adolescence. So that children that is about 8 years for up to develop this situation. And here we have the problem of the social isolation, social phobia, that may be a great problem for the development of social members of this family. This is important to tell that the symptoms affect not only the child, the symptoms will affect all the family. If you have one child with chronic seizures in home, this family most of the time will be more restricted because of this negative impact of seizures and the situation that the families almost always want to not tell everyone that the children have seizures. You have all today the situation of the bullying. Bullying in the children is a real problem, that children have a seizure in the school. Almost always the children don't want to return to school in the next day, particularly the children that are cognitively normal. So this situation of embarrassing of having a seizure in public is really a problem for this children with late childhood and adolescence patients. What about anxiety in children with chronic disease? This study is very interesting, that they show that anxiety is not a situation exclusively for epilepsy. So patients that suffer from allergies, asthma, orthopedic or respiratory distress may have a potential risk to develop anxiety. But when we talk about seizures, this situation will be present in about 6% of children that have chronic epilepsy. So chronic seizures will be a strong factor to develop anxiety in this group, but it's not exclusively. But the great problem here is that if a child has asthma, don't have problem to go to school. If you have asthma crisis in school, he just goes to hospital, will be medicated, and the next days will go to school like another children. But if he has a seizure in the school, particularly if he is a grand mal seizure, it will be a problem to return to school in the next days. And talking about the behavior problem in children, we can see here is a study from Austin in 2011 that children with epilepsy have much more behavioral problems, here in blue we see, than his siblings. So here, although these symptoms is higher in the first half of this graphic, we can see that it persists for a long time. The anxiety decreases a little bit, but it's not significantly decrease in the long-term follow-up. So these children, again, will develop behavioral problems, will develop anxiety, will develop depression, and we have to have a positive approach to these symptoms. This also occurs in all the other benign forms of epilepsy. We talked about the benign Hollandic epilepsy, but in patients with absence epilepsy, its active problems include the symptoms will be present also. It includes anxiety, depression, and in this group, particularly, the worst symptoms are not so common, but they will be present also. These symptoms of the students, you have to understand that children are not small adults, are not similar or exactly the same that we can observe in adults. In adults with depression, it seems to predispose always to see social isolation. Here, some children will manifest this kind of symptoms with nervousness, worrying, sadness, crying, agitation. So these symptoms of depression and anxiety will not be the same that found in adults. Low self-esteem will be a significant symptom here, and this talk is, I'm not good at this, is frequent in these children, and then they try to isolate and not execute that function that we expect for this child to develop. Electroencephalographic findings of age and age of onset have not been associated with depression. It means that if patients have lots of discharges or no discharge on EEG, will be significant, modify the risk or the impact of the symptoms. Seizure recurrency, high frequency of seizures, long-term duration of epilepsy, this will be the great risk of developing depression and anxiety. And this, in here, it's important to note the importance of family in the symptoms. If the family have a negative attitude to epilepsy, this child will be more susceptible to develop this kind of depression and anxiety. If family could deal relatively well with this situation, with the seizures, the child will be more protected, and in this way, it will be more easy for the child to differentiate this kind of situation. It's not different for all the disease. If you think about another chronic disease like asthma, diabetes, we can see that family attitude to the children and to the disease is one factor really important to give some kind of self-control for these children to be more positive in the attitude to this disease that this child presents. We can think that children is not able to suicide ideation, but it's not real. Sometimes we can see that children talk about death. One of the symptoms that this child may have are not just, they're not going to talk to you, I'm thinking about suicide. But the child may be some attitudes that you have to be, you have to care about that. Some of these are, they are going to draw deaf persons. They are going to talk or draw situations that one is killing another. And this child may be sometimes to put herself in a situation that death will be the end. You can see that in a game, in a fight, in a car crash. Sometimes these children are not going to really talk if I'm going to die, pardon. But they are going to talk that one situation may lead to death. This is a subtle situation, but we have to be attentive to this, because children are not possible to, are able to talk relative and directed to the point. Well, more frequent among suicides, more frequent among people with epilepsy than in general population, to be about 11% of patients with epilepsy will think about suicide. This will range through 67%. Individuals with epilepsy had a threefold higher risk of having suicide as a cause of death than controls. And here you can see we don't see only patients with refractory epilepsy, but that patients with relatively well-controlled seizures may have this kind of attempt, and sometimes complete suicide. The risk of suicide was greatest during the first 6 months from the diagnosis of epilepsy. So it's this period of adjusting situation, adjusting behavior that these patients were going to have. And this period is the most important for us to be attentive to this patient, not to commit a complete suicide. The risk of suicide in patients with temporal lobe epilepsy is much greater, maybe for some neurotransmission, or Professor Kanner demonstrated some disturbance in neurotransmission in temporal lobe epilepsy. And this is a bidirectional relationship between suicide and epilepsy. It means that patients with suicide may have a more frequent incidence of epilepsy, and patients with epilepsy may have more suicide. This may consider disturbance of neurotransmission, serotonin, norepinephrine, glutamate, and gamma-aminobutyric acid. In 2010, Kaplan evaluated children with suicidal ideation, had a significant smaller right orbital frontal gyrus, white matter volumes, and larger left temporal lobe gray matter volumes. This again demonstrates that some structural changes may have correlations between these kind of symptoms. Not just we have to remember here that suicide will be correlated with the greatest risk of depression, of psychosis, and other diagnoses. So I have to go ahead. Well, there are no epidemiological studies evaluating risk of suicide in children, and evaluating patients that attempt suicide are higher in children with epilepsy. So if you have just 2 minutes, I would like just to go through this here and talk about psychosis. Psychosis may be interictal or posictal. In children, it's more frequent interictal psychosis, and the most risk factors for children with epilepsy are positive family and history of schizophrenia, young age at epilepsy onset, cognitive delay, and complex partial seizures. In young patients, temporal lobe epilepsy is not a major factor that increases the risk of psychosis, and the positive family of schizophrenia, I told you, and intellectual dysfunction with more severe impairment of other areas may be a factor that increase the risk of psychosis. I have just one question here, that what's come first? It's a coincidence, it's a secondary to repeated seizures, it's an underlying brain disorder other than the epilepsy itself that increase the risk of these symptoms. But we see that patients with epilepsy and patients with psychiatric comorbidities are much linked together. And this is real for children also, not a problem just for adults. I think that children have the most situation that this is not frequently diagnosed, because most of the groups that work with children don't have a frequent evaluation of a psychiatric in the group. So this is a question that it's important to think about. This is a study that shows that patients with epilepsy have great risk to develop psychiatric disorders, schizophrenia, and bipolar disease, and I will go through this, and talk just about psychogenic non-epileptic seizures. This is a very interesting point here, because it's a situation that's more commonly associated with women and adults. But we found it in children, and in children don't have a specific general correlation. So we have psychogenic non-epileptic seizures in boys and in girls at the same frequency. The age specifically around 12 years is the most risk of development of psychogenic non-epileptic seizures, but we can see this situation in children younger and since 5 years of age. The diagnosis of the prolonged video EEG monitoring is the only situation that we can firmly diagnose the situation of psychogenic non-epileptic seizures. Major risks are psychological stressor, and here is the thing you have just think about, that most of the children have a history of incest and sexual abuse. It is the main cause of development psychogenic non-epileptic seizures in infants. So we have to go and ask about these things. That sometimes we are surprised that this situation occurs in the family. The diagnosis may be in younger ages. You have reported psychogenic status epilepticus in children also, not only in adults. The children generally more favorable than adults with this resolution of the situation. And just to conclude, we can see that the psychiatric comorbidities may be underdiagnosed in children with epilepsy, and we have to be attentive to this fact. Possible reasons are the presence of development delay leading to confusion of symptoms, medical inattention, our fault, and family inattention. And the current treatment may improve patients' and family quality of life. Thank you.